for Africa Advocacy Foundation, based in the UK. And I head the HIV services, but I also wear several hats, and with a special interest of Black migrant communities in the UK. Special interest in PrEP. I sit on the PrEP guidelines steering group here in the UK, and the sexual health board as well. So and mainly my role in those is a community lens and just understanding the PrEP need for Black communities. And it's nice to see you and nice to be able to have this second session. Let me share my slides. Okay, so we've done a little bit of introductions, and those are, that's my email contact and LinkedIn, and we will share these slides with you anyway, so you will get a copy of them. What I'll ask is, because I'm now sharing on the screen, Naloza, please just help me, manage who's putting their hand up and the chat, because I can only just see about 4 people on the screen. So our agenda for today, we'll start with a few housekeeping, then we'll do a bit of introductions. We'll have a very brief recap from last session, and then we'll look at the aims of today. And these aims are also looking at common barriers to migrant PrEP uptake. We will be looking at factors influencing PrEP use. We'll look at stigma and medical mistrust. We'll look at cultural and gender-sensitive communication strategies. We'll look at a few case studies, and then we'll finish off with asking you to look at an action plan or goal setting in terms of what you are going to implement in your own organizations. And I'm hoping we'll have enough time to go through all of that. The recap from the last session, we really covered so much. We started with looking at the landscape of HIV in Europe, looked at how many people were living with HIV, and looked at how many in different Eastern Europe, Central Europe, West Europe. We then looked at how many were accessing PrEP, and where the gaps were. And I believe you will get the slides, because I just shared them only yesterday from the last session, so apologies, but you'll get the slides and you can refer to them, and it's got my email if you need to ask any questions, get any further information. I'm happy to do that. We then talked about HIV prevention, where we looked at other tools of prevention. We looked at the history of where HIV prevention started with the ABCs, which were abstinence, behavior, and condoms. And we looked at the other forms of prevention, which included testing as prevention. We looked at condoms and barrier methods, femidom, dentoderms. We looked at treatment as well as prevention. And we then also looked at PEP and PrEP. We looked at the history of PrEP in terms of when it started, the trials that have been done to date, how we now have the technologies we know. We discussed briefly about PrEP being available in certain countries, and in other countries it's not. We discussed in some countries it's free, in other countries it's reimbursable through your insurance, in other countries it's not. So there were all those different landscapes that we explored around PrEP. But we then also spoke about the role of peer networks and peer navigators and peer support networks around prevention, and how effective they can be in tailoring information to groups that you're trying to reach or that you work with, so that they can see themselves in these groups, so that there's empathy, there is cultural sensitivity. So we kind of explored all those things. And I'm not going to go too much into that, because you will have the slides. For those of you who did attend, you'll have the slides and you'll have my email contact if you need further information. So if we go on to today's session, which is also quite packed, I wanted us to have a discussion. So I asked you last time to have a consideration about what you are doing already in your organizations currently around PrEP, and consider sharing with us what is working well and what is not. If I remember, there were a few organizations that were already prescribing PrEP. I think Laura in Finland, you said you were already prescribing PrEP. Luciano, who's not here in Italy, I think he said it was southern Italy, but he's not here today. But I don't know if we have, I'll change this a little bit, but if we have an organization that's already prescribing PrEP, are you happy to just share with us briefly how you do that, what's working well, what challenges you have? If I can start with you, Laura, if you don't mind, while we wait for any other offers.
Yeah, definitely. Actually, our organization, we are not prescribing PrEP because we don't have any doctors working in our organization. But we give PrEP counseling to everyone who is interested in getting PrEP, and then we also write referrals if people need referrals to see a doctor. But for example, in Helsinki capital area, the hospital doesn't need referral at all. So it's okay that people who are interested in getting PrEP, that they can just call there. And we know that for quite many people, it's might be like quite difficult to call there if they don't trust authorities. So in that case, we can write referral if it's easier, or we can call to the hospital with the client if it's easier for them. Yeah.
Okay.
And I think we are not reaching like all the right people who would benefit from taking PrEP. Meaning migrant men who are having sex with men. I mean, that's a big group, and it would be better if we would reach that group better, because it's really important target group.
Thank you. Thank you so much. Kim, I see you've raised your hand.
In our organization, we're not prescribing PrEP, but we're doing PrEP consultation since 2017 until today. So basically, we're working with the hospital. So the doctors, the doctors and the nurses and the other health mediator, they come to our association to do the consultation. So the doctors are the one who's prescribing the ordinance or the PrEP for the patients. So basically, us, what we do is we gathered patients, like for example, in my case, because I'm handling some administrative work at the same time, some health work. So when the girls come first in our association, especially if she's trans and sex worker. So basically, I talk about sexual health and prevention, and then I propose to them the consultation for PrEP if they're interested or not. So it's like a work between us, the association, and doctors in the hospital, and another association who assisted this hospital. So basically, it's a collaboration work. As what we do is we gather patients, we offer patients, we orient patients, especially our community, because as I mentioned, our community is the community for LGBT, but dominantly are trans sex workers. So that's why we have a lot of, we have a lot of people who's interested in taking PrEP, especially the sex workers. and the trans. Yeah.
Thank you so much, Kim. And we are seeing there's some similarities in terms of how you're making referrals and linking people into the doctors where they can then get the PrEP prescription. So thank you for sharing that. Anybody else who prescribes? Anybody else who has a different setting? Okay. So I'm taking it that we only have 2 experts in the room. And that's a joke, so don't take it seriously. But thank you so much, Laura and Kim, for sharing. And I'm hoping that we will go, as we go on in today's session, we'll be able to discuss a bit further. For you, Laura and Kim, you can reflect on what you're doing, see where there are gaps in what you could explore in terms of what more you could do and expand, or more still what you're doing well and see that actually that's really good. We're doing well already. So thank you so much. So if we go to the next session, so our aims for today's session are to get, let me just move just move you away from there. So it's a get a deep understanding, better understanding of the common barriers to PrEP uptake among migrant communities. We hope to explore things like the social, structural, cultural, legal factors that influence the PrEP uptake, looking at stigma and medical mistrust and how these play a role as to barriers to engagement. And lastly, looking at equipping ourselves with the culture and gender sensitive communication strategies so that we know how to engage our communities better. And I will try and be as simple as I can, especially for Francis, because I know English is not necessarily your first language. So I'll be as simple as I can. And if you need better explanation, please stop me at any time. So what we're going to do now is put you in breakout rooms. We're going to have 3 rooms. Hoping that will mean we have at least 3 people in each room. One room might have 4. And I want you to look at what barriers you've observed in your work, working with migrants. This is around access to PrEP, but it might be other barriers, because we also know, and we discussed this the last time, that sometimes it's the other issues, the social issues around that affect engagement. So other issues, what might cultural beliefs might shape perceptions around PrEP. What strategies, if you have implemented any, to build trust with your migrant, and I'm using the word clients, but it can be the people you work with, whatever word you use for them, and how healthcare providers, whether it is the family doctor, because I know different settings. In the UK, we have a GP, we have a sexual health consultant. In other countries, you have, again, a family doctor or the health professionals. How can they counteract stigma? And giving it 10 minutes. We don't have to be exhaustive, but I would also like you to choose one person who is going to feed back to the group after the 10 minutes. So Nalos, I don't know, are we okay with the breakout rooms now? I will stop sharing and try and copy that into the chat. So I thought, I know that was a very short time. I hope you still had some meaningful conversations. We are going to hear back. I hope you remember to assign one person to feedback. So we're going to hear back from each group. What I'll ask is when the first group presents, if the second group is presenting, any points that have been mentioned by the first group, you don't have to repeat. Just mention what hasn't been mentioned. And then the third group, again, it will be the same thing. You mention anything that you feel has been missed out, or if there is anything for the third group that you want to emphasize, or personal, not personal, but experiences that people may have mentioned that you'd like to point out. So if we start with room 1, and Nalozi, I think you will help me. Kim, I'm going to, can you mute yourself? I know you're working as well. Thank you. Nalozi, can you, I don't know, do you know who was in room 1?
Myself
Judy,
and
I can
Karibu.
say.
I
Okay.
think.
Okay.
So do
Yeah.
you want
Yes.
to give us your feedback?
Well, it was a very interesting one. Well, in Sweden, currently in Noah's Ark Mosaic, we don't give PrEP, but however, we offer information about PrEP and all that. And then on the side of Caribou too, they have a very good model. What we can share as a common challenge will be that most people, even having access to these or not, have other pressing issues. And those pressing issues are the issues of other social determinants of health, like job, like their housing. These are very important to them. And then putting the HIV, putting sometimes medication, even secondary. So this has actually been a very big challenge. So, and as part of the intervention, they have done food bank, free language classes, for example, in both venue in Sweden and in his own center also. We have language barrier or language problem, particularly for migrants. So in our all my model and their own model, we also have free language classes for them as a means of solution to all of this. And then we link them up with social services for them to, for example, in my own center, we do their CVs for them to be able to get something meaningful for them to do. We link them up with shelters where they can have soccer, where they can sleep and all that. So pretty much some of the challenges that we can identify. And also in my own situation, some healthcare workers don't have enough knowledge in addressing cultural nuances when it comes to migrant and key population. So we in our own center, we also do training for nursing assistants, for some other health personnel. Just to keep it short. Yes, thank you.
Thank you so much. And even though you both said you had limited experience, you were able to cover a lot of the barriers and some of the mitigations. So thank you very much. Can we have room 2? Who was in room 2? Nalozi,
In
do you
room
know?
2, we had, yes, in room 2, we had Aljaz. We also had Kim
Okay.
for room 2. Yes.
Aljaz and Kim, are you able to present?
I'm not sure if I'll do the presentation because where is my partner? I'm not so sure. But anyway, maybe I can. Yeah, you want to talk, my partner?
It's okay. You can speak about it.
Do it.
So me and Kim were mostly talking about sex work in France, in Slovenia. And we also talk about PrEP. Kim, please correct me if I'm wrong. So in Slovenia, PrEP is not available for migrants. It's only provided for those who have Slovenian health insurance. Otherwise, it needs to be they need to buy it. And what Kim said is that in France, they can get PrEP free. They also offer PrEP consultations. And they have been doing this since 2017. I hope I'm correct. For us in Slovenia, we also offer PrEP consultations to any people. It doesn't matter who you are, but like I said, it's only provided free for those who have Slovenian insurance. We basically didn't go through all the questions because we mostly spoke about PrEP in France, in Slovenia. So let me check what you're. Yes, this is what we found out. But Kim, thank you for conversation.
No, thank you. And that's why I wanted it to be in different, smaller groups so that you can share a bit more as opposed to a large group. So that is still fine. And I think we've picked up that in one country, PrEP is free. In another country, it's under insurance or you have to buy. Again, those are some of the challenges we're seeing in different landscapes. So thank you very much. Room 3, I think I know.
Laura.
Yeah.
Yeah, there was me and Bamu Francis, but I wasn't able to hear them, so I was just wondering by myself. But in Finland, PrEP is free for those who are Finnish citizens, or and also for those who have residence permit and right to like the healthcare. Right to use Finnish healthcare system. So that's quite a big barrier for quite many people. And also the queue, at least in Helsinki capital area, the queue is about 3 months. So that's quite a long time for many people to wait. And obviously there's also like language barriers. And personally, I've been thinking about my gender and me being white. That is it something that might be issue for some people? At least my gender. Like, is it really difficult to talk about sex or sexual health with a woman? And yeah, that's my plate.
No, thank you. And you did well for yourself. I first of all have to apologize because we had some technical issues. So some people couldn't join our group. So we didn't realize when we took somebody else, you remained by yourself. Apologies, but you have done
That's
well.
okay.
You presented
No
well.
worries.
Thank you so much. And then the last group that was in the main meeting room.
Yes, hello. So for barriers, we've discussed the language barrier, religious reasons, lack of education about PrEP, distrust in healthcare, waiting lists being too long, and PrEP not being a priority for migrants. For cultural beliefs, we talked about sex being a taboo and people believing that PrEP is not for them. They believe it's for sex workers or LGBT people. Some strategies are support groups from people from the same countries, peer support groups, and cultural mediation. About stigma, we think it's important to have more education, to have continuous training for healthcare workers, and also more empathy from healthcare workers. That's it.
Thank you
Thank
so
you.
much. You managed to cover a lot compared to most teams, even though we seem to have the issues and you started slightly later. But thank you very much. And I'm hoping you've been able to see the breadth from the different groups. Everyone's tackled it differently, shared a different perspective, but there's some common themes that we are seeing. And if I go back to presenting, I hope now when we talk about the issues and the barriers, I'm not making this up. At least a lot of what you have shared is going to be represented in what I'm going to discuss now. If I can just get it into presentation room. Okay, so if we're looking at the common barriers, and again, there's going to be a huge overlap with what we've discussed, but this just means it's re-emphasizing that you've done good in your discussions and that's the reality. So, you know, a lot of you talked about the competing priorities and the fact that health is not necessarily prioritized. So we know that socioeconomic challenges are a key barrier. We know that cost in terms of where PrEP is not free, or cost of living. I know the first group talked about trying to sort out CVs to get a job, trying to sort out housing, trying to sort out food banks. You know, so those are real issues. Work instability is a weak issue. It means they can't prioritize health. Unstable housing is also a very key issue. Or if somebody's in a refugee camp, or, you know, all those kind of things really affect whether they will engage in their health and taking good care of their health. If we look at structural barriers, again, some of you have mentioned waiting lists as long as 3 months. I think somebody else in the group that remained in the chat, you had, I think, up to 8 months or so waiting list, which is not realistic. For somebody to wait that long and try and have protected sex because they're waiting for PrEP is really unrealistic. Navigating healthcare systems, these really vary from different country to different country. So some of you have talked about how you've mitigated that to work with champions or peer support to help the migrants know where to go, what the system is, how they can navigate that, supporting them and linking them into services. Then there's also the documentation requirement, or for those who don't have any documentation. So all those really play a huge role in terms of access. If you think that you're going to present in a clinic with no paperwork, they may charge you, you don't have the money to pay, or you may not be seen. We also know in certain other situations, there's where, for example, PrEP might be free, but other health conditions are not free, and therefore someone prioritizes. And what's the point of me having PrEP if, for example, my maternity care is not free, or if I have any other illness, maybe I'm diabetic and I have to pay for that. So those are the kind of structural barriers that really hinder uptake of PrEP. If we go to some of them, we look at the legal concerns, and this is again migrant persecution and the fear of that, of the repercussions of what the legal aspects of that imply, restrictive policies, and these, again, we know what it's if we look at different most of the countries, the issues, there is a backlash around migrants. It's not positive politically. So migrants want to go underground. They don't want to seek help. They don't want to be seen. There's all these in terms of the political landscape that really play negatively on migrants. And this is across now most of Europe. We also know this is across the board in the US, but this is having a positive effect where you have, let's say, sex work criminalized, and then sex workers don't feel comfortable to come out and access this because of that's their livelihood, and they are fearing prosecution. So there are all those kind of issues that play a huge role that can deter somebody from coming up to take PrEP, even when they know it would be really beneficial for them. Then we spoke about language and health literacy. Maybe it's not something that came up, but it kind of goes hand in hand with language, where in many of the countries, the language spoken is not necessarily the language migrants know or even know well. Then when we look at spoken versus written, so if you're talking about spoken language versus written language, sometimes if I think somebody gave an example in Sweden where you do language classes, and so somebody may learn how to go by speaking or Swedish, but when it comes to reading Swedish, that's a different ballgame. Then when it comes to health literacy, meaning reading health information, let's say when they have a prescription, when they have to read medical information, then it even becomes more complicated. So those are some of the barriers that you find. And then the literacy within migrants themselves can also be an issue, where migrants have not had a good education, and therefore their literacy levels in whatever language are very low. Their ability to write and express themselves is also very low. So we know that those are barriers. Even when we look at translations, when you're trying to translate certain words into dialects, they don't exist. For example, if you are trying to translate to a migrant who speaks I'm trying to think of a language, but even if let's say Arabic, is there a word that translates PrEP, for example? How do you translate that in Arabic for somebody to understand what it is and what it can do for them? So there are times when certain words don't exist in the dialect, and how do you then navigate translating that so that it makes meaning and sense, and people are able to understand and make an informed decision? So those are some of the challenges that we find commonly. Then if we take up factors influencing PrEP uptake, again, these are things you've discussed around cultural beliefs and norms. I think it was I'm looking for her, the lady who stayed by herself in room 4, Laura, I think, who mentioned, the taboos around women not wanting to discuss, men may not want to discuss sex with a female. There is also the power that maybe men have in certain relationships over women, or in same-sex relationships where there's a fear of talking about their sexuality, and because of culture norms, and those also play a huge role, especially with migrants who may not be very open with their sexuality, and fear of being rebuked or judged. So those play a huge role in terms of how someone will access or influence uptake. In certain cultures, sexual health is not something discussed. If it is, it's in very negative forms, or it's hush-hush. So all these play a huge role in terms of how someone comes to talk about taking PrEP. We know in certain communities, certain cultures, sex is normal. They talk about it openly. But in some other cultures, that's a no-go area. In certain other cultures, you have to be sensitive in how you talk about it. So those are the kind of influences. Then there's also the power and gender dynamics. Again, where I was talking about maybe in certain cultures where a man has more power than a woman in their relationship. So if they are if they're in a relationship and you're talking and they come to you and you identify that let's say the female would require PrEP, they have to consider, what does that mean in their relationship? Are they able to have these discussions with the partner? Are they able to maybe not have the discussions? How are they going to take PrEP without informing the partner? Sometimes that's been linked to violence. So there are all those other dynamics that play a huge role. So it's always good to understand what are these influences that might affect those decisions. Then religion, and I know again somebody mentioned, I think the last group mentioned religious barriers, and what the role of religious institutions play around the defining and shaping of sex. In certain religious spaces, a condom is not advised, it's not recommended. They want you to have as many children as you have. So in other spaces, sexuality, in other religious spaces, sexuality is an issue, and therefore some people feel that then becomes a hindrance in them seeking the help that they need, because it involves them disclosing what their sexuality is, and depending on their religious background or influence, that may make them feel ashamed, or already the religious institution labels them as a bad, or whatever they're doing wrong. So all those play a factor in terms of how people then uptake in terms of their uptake for PrEP. And these also don't sit in isolation, they intersect. So you have to look at the intersectionalities of a person in front of you. They might have language barrier, they have the cultural norms, they have the religious influence, and they have power dynamics, or they have poverty. So we have to look at all of those intersectionalities when you're trying to work with somebody. And then there's the perceived risk. And I think this is, again, something that a lot of you spoke about, in terms of a lot of people thinking they won't benefit from risk, or they don't even need a condom, or they don't need to wear a condom, or HIV is not something that's going to affect them. So that is a huge barrier for them to make the connection to why they would benefit from having PrEP. And I would like to go a bit further into that and discuss it in this table. Let me just move you across and discuss it in this table. So looking at, again, in depth, some of these issues in terms of limited or poor risk perception in relation to HIV, again, where they feel that's not something that's going to affect them, or, they would know before they sleep with somebody, they will know if they have HIV or not. There are all those kind of perceptions. There's the lack of awareness around PrEP itself as a tool to prevent HIV in many migrant communities. There's uncertainty around its efficacy or their eligibility for it, and therefore feel, it's there, but maybe I can't benefit from that. In last week's session, there's somebody who mentioned, I think it was Lillian, who mentioned that PrEP in Germany, the posters they saw were mainly for men who had sex with men. So a lot of heterosexuals felt, PrEP is it's not for them, it's for men who have sex with men. So it's those kind of things of candidacy not being realized. There's the low underestimation or underreporting of risk behaviors that leads to low self-referral. So feeling that, I only have 2 partners, or in certain cases, I know all my partners and therefore I don't think I need PrEP, those kind of things. There is people who are in non-exclusive relationships and may not necessarily make that connection because for them that's culturally what they do. It is normal. But if you bring it up as a risk, then you're trying to make it look like it's a bad practice. And there's that tension between the culture and what is their risk, if you like, or vulnerability to contracting HIV. I mentioned in the last session, I prefer to move away from using the word risk to vulnerability, because sometimes it's just somebody's way of life, and to call it a risk, it's a form of a judgment in a way. Then there is limited knowledge of PrEP. Again, you've mentioned this by health professionals and also the cultural sensitivity as well within health professionals. So those are some of the things. And this can be divided, plus all the what you've discussed and fed back in our breakout rooms today, can be put in this table where you have 4 different categories. You have, they don't perceive themselves at risk at all. They perceive themselves at risk, but the services are inaccessible. The waiting times are long. The cost of PrEP, they don't have documentation. So those can play a part in that. Perceive themselves at risk, but the services are unacceptable. So again, they might know they're at risk because maybe they are from the LGBTQ, they are trans, they are sex workers, but because of religious behavior, because of criminalization, they feel it's unacceptable for them to access services. And then we also have the perceived risk where services are accessible and acceptable, but they just won't go because they don't feel that the services are designed for them. They feel the healthcare workers don't understand their need, or they don't know about PrEP, or there are language barrier issues and the service itself is not designed for them, so they won't go. If, for example, that clinic is opening maybe between 8 a.m. and 5 p.m. and they work between 8 and 5, they can't go to the clinic. So it's those kind of things, and it's grouping them in that to understand where this perception around risk and how you balance it with the need for PrEP. I hope I'm with everybody. I have spoken a lot. Do we have any questions before I move to the next segment? Nalozi, I'm hoping you're looking at, I can't see any hands. Okay, I can see a thumbs up. Okay.
Yeah.
So if we go to stigma and medical mistrust, a lot of it is around, stigma in general in migrant communities. HIV has never been a sexy topic. So there's a lot of HIV-related stigma in very many communities, fear of being labeled as a promiscuous, or even fear of, if you have PrEP, that means in some communities, because PrEP oral pills look like HIV medication, some of them have reported that if I take PrEP tablets home, my community is going to assume I'm taking antiretroviral tablets, therefore they're going to assume I've got HIV. So there's all that PrEP-related stigma as well, that we cannot hide away from. A lot of people, that's why for those who countries where injectable PrEP has been commissioned, there is an appetite for that, because it means that, one, it's long acting, two, it takes away the stigma of having the tablets with you. We have, I have a lady I was supporting who was in a relationship where she identified she would need PrEP because her partner had several other partners. He used to travel back home regularly, and she was aware that when he traveled home, he had other sexual partners there. So she wanted to protect herself, and she took PrEP, and he found the tablets, and that caused a lot of mishap in the relationship, and eventually the relationship broke down. So there are those real fears that we have to support the community when we are trying to balance the need for PrEP and all the other stigma-related issues around having PrEP. Then confidentiality is also a very, very huge concern when we know that in certain communities, the clinic for PrEP is in one place, and if that information is shared with the community, or if people are seen going to the clinic, they make assumptions. All those are real concerns. How safe is the information in healthcare settings is a huge concern. Or, for example, if I'm undocumented and I know there's free access for PrEP, but is that information then going to be shared with the authorities that I am an undocumented migrant accessing care? And that really makes people think twice as to whether they should actually access any services or remain underground completely. Sometimes that's where community organizations are more favored, because they know they have their interest at heart, as compared to the health facilities that are managed by local government officers as well. Then again, if we're looking at medical mistrust, and I think this came up again, a lot of you were talking, they don't trust health professionals, they don't trust the science around PrEP. There's the historical mistrust. Some of it is colonial, some of it is through trauma. So again, that plays a very huge role in terms of immigrants not trusting the system, or in terms of we've got to make sure that when we're advocating for PrEP or any other sexual health services, that there is consistency, there is transparency, and it is respectful, so that it's person-centered in terms of how you're delivering the care, so that the person in front of you is able to see that you're taking their needs into consideration and not necessarily just doing a tick box exercise. And then sometimes it's also the clinical guidelines that inhibit access to PrEP. And if I go a little bit into that, in certain criteria. For example, here in the UK, they have amended this now, but at the time, the criteria for anyone who was eligible for PrEP was that they had to be men who have sex with men, or bisexual men, trans sex workers, and people who inject drugs. And the heterosexual was not as much, and women really didn't feature as much. And normally with a woman, in terms of accessing their eligibility for PrEP, it was based on their male partner's characteristics. So it was, is your husband having sex with men, or is your partner having sex with men, or is your partner living with HIV, or is your partner injecting drugs? And that would be the criteria in which you would qualify for PrEP. This has changed, but this really disfavored women at the time. And it meant that women's risk perception or vulnerability perception was not looked at as their own need. Even where women said they had more than one sexual partner, they seem to be dismissed. So it's really that, what are the guidelines, the clinical guidelines in the different countries you operate in, and how are they favorable to anybody who may benefit from PrEP as opposed to certain characteristics? I think it's something you can reflect upon and lobby for if you feel that that needs to change. Then we also know things around discrimination, racism, and exclusionary practices also play a very huge role in many people's accessing of services, where they may feel that racism plays a huge role. They don't feel welcome, where they feel there's discrimination because they're migrants. They will not access these services. And this, in clinical settings, we have to make sure we're mindful of those inhibitors so that people can feel welcomed to access services. Stigma, even in healthcare settings, is really huge, where there's judgment around a person being a migrant, around their sexuality, around their way of life, if they're a sex worker. So those biases still exist, and stigma still exists in those settings. So it's really trying to make sure that we combat and challenge this behavior in medical settings as well. And then there's the difficulty of talking about sex in general in many communities, but even for the healthcare providers themselves, even though that's what their role is, so many people are not very comfortable talking about sex, and sometimes refrain from having these conversations with their clients or community, the people accessing their services. So those are really key reasons that we see that challenge uptake of PrEP mainly. When we look at cultural and gendered sensitive strategies, what we would look at after what we've discussed in terms of all those challenges, how do we make sure that we are providing a service which is inclusive, which is non-judgmental, which includes language that is non-judgmental? We have to be very careful. How do we frame that so that it is a service that makes everybody's needs welcomed, where they feel seen, heard, and valued, and therefore will be able to be honest around what needs they have and get the service that they require. Where there is gender affirming communication and making sure that you understand the different gender, if we are working with trans community, what are their needs? And depending on the gender, you're making sure you're tailoring that service. So more, again, emphasize around person-centered care. Then in terms of working with communities and community leaders, and these can be faith leaders, they can be community leaders. In a lot of migrant communities, there are always informal leaders within these communities that you can work alongside to communicate messaging with that community. And because they're already trusted, you already have one foot in the door. So again, that's a very good way to make sure you're sense checking how you are pitching. You're making sure it's tailored and it's culturally sensitive. making sure that you offer multilingual materials or interpreters where possible. But even when you're offering this multilingual materials, let's also be mindful that some people, even though they tell you they speak a particular language, they may not be able to read that particular language. So again, going to person-centered, you make sure you're catering with the material you're giving. Are there digital options that can speak and have an audio link so someone can hear if they can't read? Do you have access to interpreters? And that can also offer a better person-centered kind of service. And through all of that, you're building trust in the community that the community that you're trying to serve. You're building trust, you're being consistent, you're being respectful. All these are really, really key strategies that you can use. And I want you to reflect on the services you provide, what it is that you're already actioning in what we've discussed so far. What do you think you need to work a little bit better on? Where do you think you can do alliances or work in partnership? Because you may not have all the skills, but where can you work in partnership? If you can work with the small community-based organizations, that may be a better input. Maybe you're the small community organization. How can you work with the clinic or the hospital that you're linked with better to help with the cultural and gender sensitive issues that may hinder uptake of PrEP within those communities? I realize I have spoken quite a bit, and we have just under 30 minutes left. I'm going to go up. We have another session that around the case studies that's left, which is quite interesting and less of my talking, and I hope you will find it also useful. So practical approaches, again, we're looking at co-production, which is very key. You know, things that have always been said by communities, that things have been done for us but without us. So in making sure that it is with us and for us. Making sure that right from the beginning of communication materials, service design, you're working together with the community to co-produce, and therefore you make sure that whatever you produced is culturally responsive to the community you're trying to engage. Let's also try and normalize PrEP. I say, you know, we've normalized condoms, we've normalized contraception. So trying to normalize PrEP and bring it into everyday settings as opposed to something that is as a by the way or is labeled at the because of sexual practices. We normalize it for everybody, whether you take PrEP or you don't, at least get to know about PrEP. And then the use of lived experience is very key. So if you are able to have people who have used PrEP to talk about their experiences, whether they, I think there was one particular person who said they match people who are already taking PrEP with the new people on PrEP, so they can support them through that. And I think that's very key. Having resources of people who have used PrEP to talk about their experience, to share their experience, is also a very, very good way. So the lived experience, the peer support along that journey also plays a huge role, and in terms of making sure people adhere to PrEP once they are on PrEP, supporting them through that, and you're able to identify any gaps and mitigate any problems that may come up as a result or along someone's PrEP journey. So we're going to look, this is just, again, I shared this the last time, and I put it in here again today. And when we share it with everyone, you'll be able to see some of the case studies in different countries, how they're engaging women, in some African women, how they've designed PrEP workshops, how there are different kind of approaches to how different countries and have tried to engage people in terms of PrEP uptake in different parts of the world. And I'll share this with you. Then these are, again, some other case studies, again, different programs, some of which I have been a part of, some of which I know of and have worked. There is PrEP for Women, which provides resources for women around PrEP. It's tailored to women. It's been translated into different languages, Spanish, Arabic, French, Shona, Swahili, I think Italian. And if you go PrEP for Women website, you'll be able to see very good resources. There are videos as well. So those are some of the videos that were produced around PrEP awareness. And if you are very lucky, you will see one I was involved in as well. So this talks about PrEP for trans community, PrEP for sex workers, PrEP for people in the porn industry, PrEP for heterosexual men, PrEP for heterosexual women, different videos speaking to that, kind of very helpful. There can be training tools that you can use during your workshops. PrEPstar is another organization that has produced a number of very good resources. They also have resources that you can use when you're doing trainings. You are able to download that. They have resources for men who have sex with men, as well as resources for young heterosexual Black men and women. There is also another project around PrEP for women that was done with small Somalian community, for the women in the Somalian communities to understand the risks around vulnerability around their culture and how they can protect themselves. So there are different other programs. And again, we will share this and you'll be able to see that. And then there's one particular program that I was involved in called PrEP and Prejudice, a campaign. This is one I wanted to share how we came about developing it, what we did, what our aims are, what came out of it. And hopefully this gives you a good guideline. I am also very aware this is mainly for Black heterosexual communities, but you can use this kind of some of the templates and themes to tailor it to the community that you are working with, whether you're working with the trans, whether you're working with sex workers, whether you're working with the LGBT or men who have sex with men. Again, you can tailor this, but the concept, you know, is what I want you to get out of this. So this, at this time when we did this, it was a partnership with 6 organizations, and the 6 organizations had different things they were bringing to the table. So House of Rainbow worked with Black LGBTQ community. FAWA was French-speaking African community. Embrace was working with Horn of Africa community. And we had another AGRO, which was Black men, heterosexual men living with HIV and also working around prevention. African Health Policy Network was working with more African and in general, then Africa Advocacy Foundation, which was working mainly with diaspora Africans or Black heritage people in the UK. And these formed a coalition to produce this, with those strengths from the different organizations, to produce this program that was benefiting people Black heritage in the UK. So the approach that we had was to create unique messaging, which was answering the needs or what we had identified, that a lot of the PrEP messaging did not reflect the community, Black heritage community. So it was finding universal African phrases that are popular, that resonate with this community, that are understood by the diverse communities, making sure that these are co-produced with the community. So they're community-driven campaigns with community-facing in terms of imagery, in terms of the comms, all that, making sure it's community-facing. We made sure we have engaging flyers and posters and digital content, and so that it resonated with the community we're trying to reach and target. And in terms of our objectives at the time, it was increasing knowledge and of PrEP, increasing uptake and access, reducing stigma associated with it, with PrEP, also increasing professional awareness around PrEP with experts and professionals, and may also upskilling our own community, the champions and ambassadors that we worked with around PrEP, so they were able to learn more and then cascade and deploy this information within their own communities. What we wanted to get out of outcomes was make sure that there was clear understanding of the perceptions and attitudes of PrEP for Black African communities, which was evidence-based. We wanted to have open discourse on PrEP among the Black communities within a cultural context, utilizing innovative and cost-effective approaches to influence the attitudes, and key co-production and successful launching of innovative digital content that can be used by this community, that can be shared informally through different channels on social media, and reach the community. We used methods of PrEP, developing PrEP awareness campaigns, destigmatizing and encouraging uptake of PrEP through referrals directly into clinics where people can then get their PrEP prescriptions. PrEP in the UK is free, so we were able to tell people that it's free regardless of whether you are documented or not. Then we were also able to create digital content that could be cascaded through things like WhatsApp, because that's how we know the community we're targeting communicate into WhatsApp forums or groups, community radio stations, which are normally online, Facebook and Facebook live programs or groups that we knew exist. And then also creating a tool, an educative tool for health workers and for PrEP champions. So the outcomes of this project where we were able to recruit and train 32 community PrEP champions, and we were able to also recruit 3 PrEP users who also became champions to talk about their experience. We trained 68 frontline healthcare workers. We did this through different focus groups. We held pre-production focus groups that informed the messaging and the imagery and the themes, and we then produced a website, posters, leaflets, jingles that went on radio stations. We did workshops and collaborations with other organizations. There was a magazine, a radio, clinicians, and totally we reached over 66,000 members of the community. And then also some of that, we produced a toolkit and we produced a training manual. Some of the imagery that came out of, we put out an ad for models. These models put themselves forward. They're from the community, vibrant, but that meant they were true reflection of the community. People could see themselves in those images, in those people, and for some they even knew them, so that meant that it was relatable. Then we also did the co-production where we came up with how can we talk about PrEP. So it was PrEP is a pill that can protect you from getting HIV. PrEP is free. It gives you a peace of mind. PrEP is, with a PrEP, everything is going to be all right. If you don't know your partner's status, you might want to think about using PrEP. All those were things that came out of the co-production in terms of key messages, how we can talk about PrEP. I'll skip the findings and go to the recommendations. The recommendations of this project talked about demystifying PrEP misconceptions. There was a lot of poor PrEP knowledge, but a lot of misconceptions. We also found that the resources we produced resonated with the community really well. The language used resonated with the community as well. I'm going to show you some other messaging that we did. There was a huge lack of basic knowledge and facts around HIV for a start. Even before we could start talking about PrEP, we had to talk about facts around HIV, bringing people's knowledge up to date with current HIV knowledge, and addressing stigma associated with using PrEP, and also establishing a network of PrEP users so that they could support each other. So those were some of the recommendations that came out of that. And I will let you see when we share these some of the conclusions, but what I wanted to highlight was some of the resources that we developed. So we developed certain key themes. like with PrEP, no Wahala, which came again out of co-production, which was really easy for people of West Africa. But generally, we know the no Wahala slang in the Black community, and that really resonated well. It was a talking point, a starting point, a conversation starter. With PrEP, Hakuna Matata, which again is a universal term, but also resonated well. With PrEP, No Worries was a spin of Bob Marley's song No Worries, again, which resonated well. Then we had Are You Prepared for a Healthy Sex Life? Again, so those really resonated well. And we also did some video content as well. We also engaged in radio station interviews. We brought HIV consultants into radio spaces, into online Facebook channels to talk about PrEP, to talk about HIV, to do myth busting. We did translate information into different languages like Twi from Ghana, like French, like Portuguese, so that people could understand the PrEP messaging in these different languages. So those are the kind of community sites we did. We updated the PrEP campaign to new images. And again, this is giving you a flavor of what the resources we created looked like. What came out of some of our consultation was around making it clear to people that you didn't need identification when you are going to a clinic to access PrEP. They wanted to see that on the flyer, so we put it on there. So for those who were undocumented, they would not feel deterred from attending clinic. Others felt they wanted clear information where the clinic was because they didn't know how to Google information. So we put the clinic address there on the flyer so they knew exactly where to go. So those are some of the things that were developed out of co-production and continuous checking. Again, these are different upgrading of the campaign with different images, but still the theme of making them vibrant and resonate with the community. We produced a film that I want to play, a little clip that I want to play. And this also helps you understand when you're trying to tailor something to a community, making sure that even when you're producing the digital content, it is information that they understand, that they can see themselves in. So I'm going to stop sharing here and try and play this in a different channel.
Hello, my dear. Hello, Mum. How are you? I'm back from uni now. I've just gone to the pub with Rory and Brian. I'll be back home later.
We thank God. How was your journey back?
Fine. I got my train early and there weren't too many people, so I managed to get some emails and reading done on the way.
That's good, my dear. I'm so glad you are back home safely. But remember, don't stay out too late, oh. You must have learned while studying for your public health degree the importance of a good night's sleep and the dangers of binge drinking.
Of course, Mum. I'll be back in a few hours.
Okay. Here, my love. Why would Lillian send this to me?
You can't tell someone's HIV status just by looking at them. Nowadays, people living with HIV can keep well by taking medication to manage the condition, but prevention is better than cure. Did you know that PrEP is an HIV prevention tool?
Hello, Mum.
Ah, my baby returns home. Tell me everything. Oh, I wanted to ask you something. I received a video from Lillian today. At first, I thought, what is this rubbish? But then I thought it sounded like it would be good for your brother when he's going out gallivanting the streets. A drug called PrEP or something. Have you heard about it from your studies?
Yeah, PrEP is great. What makes you think it will be good for Benjamin?
Well, it prevents you from contracting HIV. And I think a man should be careful of these things on his travels. I always advise him, use a condom. But why not take extra precautions?
PrEP's good for men, women, non-binary people, well, for anyone who's sexually active or feels an extra risk of contracting HIV.
Women take it too? Isn't that a bit unladylike for women to prepare for sex like that?
You could say it's a humanitarian act, Mum, like wearing a mask during the pandemic to help stop the spread of coronavirus. By stopping yourself from contracting HIV, you're also helping to prevent the spread of the virus. Across the UK, over 100,000 people live with HIV. My friends that I was with today, Rory and Brian, they're a couple. Brian has HIV and is on medication that helps his viral load stay undetectable.
Undetectable? What does that mean?
It means the HIV levels in Brian's body are so low that the virus cannot be passed on. As long as Brian continues to take his medication as prescribed, he can't pass the infection on to Rory.
I never knew that was possible.
They call it U equals U, which means undetectable means untransmittable. So if a person living with HIV gets to a point where their viral load is undetectable, they're not able to pass the HIV virus onto their sexual partners.
Wow, that is amazing.
Yes, Mum, it really is. So although Brian is undetectable, Rory takes PrEP to prevent himself from contracting HIV from his other sexual partners as they're in an open relationship.
What do you mean by open relationship?
This is when a couple may be together, but may also have other romantic or sexual partners that they see from time to time.
What if they want to see other people? Why are they together?
But in some cases, Mum, it may not be so open and honest. Some people are just unfaithful and have other sexual partners without their partners knowing. Others may have friends with benefits situations where they have sex with a person in exchange for food, rent, educational fees, or somewhere to stay. There are many types of exchanges.
So much has changed since I was growing up. Well, I guess they've always been philanderers.
Exactly. That's another reason PrEP's great. It's relevant to all of us. Even in supposedly monogamous relationships, we can only really be sure of our own behaviour. Plus, not everyone is aware of how often testing is required and that HIV can be symptomless, so they could be unknowingly putting you at risk. PrEP saves you from the ignorance of others and puts the key to your health in your pocket. Also, life happens. Things don't always go to plan. While everyone should use protection when they're in a non-monogamous or casual situation.
Of course.
Sometimes they don't. PrEP gives you the extra protection, that extra peace of mind.
You are such a clever girl. Now you mention it, you know Grace. That her husband is always traveling back home, and she suspects he may be seeing other women on his travels. Maybe she would benefit from PrEP.
It sounds like she might. Lots of us could. Whether it's because you come from a culture where multiple partners are common, or you're unsure about how faithful a partner may be, or a partner enjoys visiting sex workers.
I suppose you're right. It does seem like this medication could benefit a lot of people. It's crazy to think how far we've advanced because of clever people like you.
Well, I didn't invent it, Mum.
But you are spreading the word, and that's equally as important. Good night, my dear.
Good night, Mum.
God bless you.
So I hope you are able to follow that. And I'm not going to discuss it because of time, but there are so many things that we had to put into consideration to make sure it spoke to the community we were trying to target, made sure that it covered a lot of information so that it put context in, and also made it as real as we can for the community we were trying to target. And you know, producing that kind of clip can also help you if you're doing cascading information in WhatsApp groups, or even doing training materials for community members. We also did another one around a PrEP user who talked about their experience, and you will get the slides and the links so you can look at that as well. But I thought that it would be good to share that. looking at how we actually do the work in the community, on the streets, in marketplaces, in hairdressers, in barbershops. So you go where the community is and not wait for the community to come to you, I think is something key that highlights. And this was revisiting the key principles of effective implementation of a program. So again, reflecting on what you're doing and what we've learned today, you're making sure you have stakeholder engagement, you're making sure you're providing a stigma-free environment, you're making sure that you're providing population-wide based on need, you're making sure you're providing a holistic one where is combination of STI and HIV prevention in your service, you're producing and PrEP awareness and demand creation. There's clinical and public health guidelines incorporated. There's standardized eligibility criteria, clear and people are aware about it. There's proper linkage into care. There's support for continuity on PrEP, and obviously there is monitoring and evaluation. So this framework really will help in terms of setting up programs that really make sure that PrEP is something that is reaching the community that you want. So what I would like you to go away with is looking at reflecting on this, those of you who are already running PrEP programs, what are you doing? What could you do better? For those who aren't doing any PrEP programs, from what you've learned last week and today, you're able to set some goals in terms of what you need to put in plan to put up a PrEP program, awareness or discourse. What key steps do you need to follow? How do you build that long-term trust with the community you're working with? If you don't have peer supporters or peer navigators, how can you incorporate those? How can you work with trusted community links and influencers? So looking at all of that, and because of time, we are not going to do this, but I want you to go back and do this as a personal reflection so that you can see how you can implement that. So I know that we talked about what we wanted to get out of the session, and I believe we've covered most of that. A lot of you wanted to see how this can work, how you can tackle barriers, how you can create strategies, and I'm hoping we've covered most of that. In terms of key takeaways, reflect on the service you have. What can you do better? You have my contact details. If you need to ask, if you need to have a separate chat, I'm more than happy to support with that. And evaluations and next step, Naloz, I think, can talk about the session that's coming up next week, I think, which is the last session. And I believe there will be an evaluation as well at the end of this. So thank you very, very much. I apologize for going over time. And if there's any burning questions, I can take one or two. Thank you very much. Any questions?
I don't see any hands on my side, Judy.
I don't either. Okay, if there are no questions, I'm happy to hand over back to Nalozi. But thank you very much.
Thank you so much, Judy. We really appreciate today's session was very engaging and very interactive, and we were able to just discuss our experiences in our individual countries. Thank you so much, everyone, for participating, and thank you for joining us today. We have our last session next week. You know never to miss the last session. So we have our last session next